Are we live?
Yes, sir. Just now.
Can we start?
Yes, sir.
Okay,
You,
you
you,
can.
you can start. You can start.
Yeah, shall we go ahead? 8 and 8. Hello.
Yes, sir. Shall I go ahead?
Yeah, please go ahead.
Good morning, sir. Now, first, I sincerely thank Dr. Srinivas, sir, for giving me this opportunity. Now, my topic today is the antibiogram, the key considerations for its development and utilization. So, first, what brings us here is the three questions. Is a patient really having an infection? What is causing the infection and how to treat the infection? So, what are the five rights of the patient? The five rights of the patient are the right diagnosis, right drug to be given, right dose, right duration, and right to de escalate when needed. So, according to Anand Kumar, in a survey, over the first 6 hours after the onset of persistent hypotension, each hour of delay in effective antimicrobial therapy was associated with a mean decrease in survival of 7.6%. So, it is necessary to diagnose early, give the drug, right dosage, and duration at the earliest. So, what guides this? Antimicrobial stewardship. The Society of Healthcare Epidemiology of America defines antimicrobial stewardship as coordinated interventions designed to improve and measure the appropriate use of antimicrobials by promoting the selection of the optimal antimicrobial drug regimen, dose, duration of therapy, and route of drug administration. So, what the core elements of stewardship are prescribing the antibiotic when they are needed, giving the appropriate antibiotic and dosage, using the shortest duration of antibiotic based on the evidence, reassessing when culture results are available, supporting the antimicrobial resistance surveillance and hospital acquired infections, and monitoring the antibiotic consumption, educating staff, supporting interdisciplinary approach, enhancing infection prevention control, and controlling the source of infection. So coming to the interventions, the surveillance and antimicrobial susceptibility testing, antibiogram, antibiotic policies, and core interventions of prospective audit and feedback, pre-authorization of formulary restriction, infection-based interventions, point of care interventions like dose optimization, de-escalation when needed, and conversion from IV to oral. What is the role of antimicrobial stewardship program in antibiogram use? An effective antimicrobial stewardship program results in improved clinical outcomes, minimal patient toxicity, and reduced antimicrobial resistance. So, what the number of purposes they include are recommending empirical therapy for individual patients, developing treatment guidelines and algorithms, making decisions about the formulary for antimicrobial agents. They also monitor trends and changes over time. They are used as an educational tool for discussion of the local susceptibility patterns, and their stratified antibiograms are needed to improve the predictive validity of antibiograms for individual patient cases. They are also integrated in the electronic health record and ICMR networking by collaborating with other hospitals to decrease the resistance. So in India, what we can do? We can limit the surgical prophylaxis to 24 hours, avoid prophylactic antibiotics, send cultures before giving antibiotics, encourage accurate diagnosis rather than empirical antibiotics, avoid empirical antibiotics for fever in hemodynamically stable patients, select empirical therapy based on the guidelines, get the dose right, avoid combination therapy, de-escalate when needed, and limit duration of the therapy. So how does this antibiotic resistance occurs? As we all know, when the high number of bacteria, a few are resistant, when antibiotics are given without there is any need, the good bacteria also dies, protecting the body from infection. The resistant bacteria now transfer their drug resistance to other bacteria, causing more problems. Uh, so there's a killing paradox of antibiotics. In countries where they use high antibiotic usage is there, there are more resistant bacteria. In a country where low antibiotic usage is there, there is a less resistance for bacteria. So according to old study in US, when initially the antibiotics were developed, the antibiotics caused the US deaths to decline by 220 per 1 lakh in 15 years. That is from 1930s to 1950s, 60s. And after that, all other medical technologies reduced deaths by 20 per 1 lakh over the next 45 years. So that is one from 1930s to 1970s, there are too many new classes of antibacterial agents were developed. After that, there is a very decline which is causing the antibiotic drought. So by 2050, there is a decline over, there is a death of 10 millions with antibiotic resistance. So we have to preserve antibiotics. So now I'm introducing antibiogram. What is an antibiogram? An antibiogram is a report generated from antimicrobial or antifungal susceptibilities results that lists in the percent of organisms isolated that are susceptible to the antimicrobial agents. The the antibiogram typically includes data from a single healthcare facility or a health system in a defined time frame. It displays the facility's pathogens and susceptibilities. The antibiogram is an essential resource to track changes and tool to predict antibiotic therapy. So what are the different types of antibiograms? The routine antibiograms or single facility antibiograms are most commonly used for susceptibility testing data and healthcare facility. The traditional or abbreviated the simplified version of traditional is abbreviated antibiogram, where most common pathogens and antimicrobials are tested and used for treatment for the clinician. Enhanced antibiograms are syndromic specific. When the pathogen which is specific, like urine cultures in UTI, they are taken and they are used for the empirical therapy. They are precise. Rolling or real-time antibiogram, these are statistical valid. Most current data is used, so real-time access up-to-date trends are used. The statistical data validity is high because they use at least 30 isolates. Shifting time frame, they have a longer frame or they usually change accordingly. Advanced antibiograms, there are two types, combination and escalation. Combination is an antibiogram where at least one drug in combination with other will be effective against a given pathogen. This is especially used for a polymicrobial infection. Escalation, we usually have a higher susceptibility rate to antibiotics based on their resistant patterns. We should immediately escalate the antibiotic. So what are the advantages and disadvantages? Traditional is readily available, easily understood, easily incorporated, and can be used for empirical therapy. What are the disadvantages? Minimum of 30 pathogens per year are required. Antibiotic breakpoints may not be included. Lack of inclusion of infection source, binary measures, susceptibility or not susceptible, lack of incorporation, and limited correlation. Combination antibiotics, we have this ability to evaluate coverage of multiple antibiotics, ease of completion, useful in determining combined empirical antibiotic regimens for multi-drug pathogens. Disadvantages are they are less easily understood by prescribers, typically requires manual completion, lack of CLSI guidelines, require minimum of 30 pathogens, and lack of incorporation as like traditional antibiotics. The syndromic specific provide effective empirical therapy for specific infection syndromes. Maybe further stratified based on hospital location, increased granularity for resistant awareness, may be incorporated in disease state treatments. The disadvantages are typically requires manual completion, less easily understood by prescribers, lack of incorporation of patients' variables like age, gender, and comorts, and lack of correlation. Weighted incidence syndromic antibiograms are ability to incorporate is their real-time decision making can be their empirical therapy. Integration of patient variables are there. Empirical antibiotic therapy recommendations for specific conditions can be done. But it requires a manual completion, collaboration, easily understood by prescribers, less easily understood by prescribers, lack of patient variable standardization, lack of correlation. So according to this way, weighted incidence syndromic antibiograms are best. What are the components of an antibiogram? Usually the time frame has to be included, facility name, methodology, list of organisms, number of isolates analyzed, and list of antibiotics and person susceptibility. The additional or supplemental information can be given with data collection cost, source, formularies, facility specific, and susceptibility trends and genetic markers of antimicrobial resistance. This is an example of an antibiogram where this is done in one hospital, Department of Microbiology, department name, time frame between April to June. Percentages shown are susceptible. Only first isolate of the patient are included. With number of isolates is less than 30. So what are the organisms are on the top, and left we have seen all the antibiotics susceptibility rates. According to CLSI guideline, the Clinical Laboratory Standards Institute recommends the following guidelines for antibiogram development. Then frequency of data reporting, exclusion of surveillance isolates, and screening cultures. First isolate only has to be cultured, the minimum sample size of 30. Routine antibiotics only, exclusion of antibiotics tested on resistant isolates only, and reporting format. So what they do, they standardize antibiogram development and ensure accuracy, a guide on data collection, storage, analysis, and presentation. Includes recommendation for stratifying data by body site, hospital unit, whether ICU or ward or OP or patient population. Updates in M39 include lab data management and enhanced presentation methods. Adoption rates, despite the importance of M39 guideline, many institutes do not fully comply with adherence rates of 47 to 60%. So studies have shown that all hospitals meet key recommendations such as minimum of 30 isolate per species for statistical validity, which is also not there. Improving accuracy, use of software tools like UNET and MedMind and other streamline the data generous analysis process, additional stratification. The importance of validating data from different systems and include all results is critical for unbiased susceptibility data. Future, we have to follow these guidelines. Institutions should explore enhanced antibiograms for more targeted and effective therapy. What can an antibiogram be used for? It can be used for empirical therapy guidance, treatment selection before organism identification, antibiotic selection based on the susceptibility percentages, like high risk patient 90 to 94% susceptibility and low risk for 80 to 85% susceptibility can be taken. But clinical context is the main thing. Considering the infection type, illness severity, hospital or community acquired, past treatments and local guidelines along with antibiotics. Multi-facility and regional antibiograms can also be developed. What are the limitations? Lack of time relativity. They do not include the time when the patient has come and when the culture is taken, or whether it is a community onset or hospital onset acquired infection. Culturing practices, not culturing the uncomplicated infections, shows a bias in this. Whether it is a pathogen or colonizer. Not helpful for recurrent or recent infections. They do not support empirical therapy decisions for patients with a recurrent or recent infection. Patient-specific microbiology results and antimicrobial history are the best treatment options in these type of patients. Limitations of an antibiotic. Missing pharmacokinetic factors. They do not account for pharmacokinetic factors such as site of infection, pharmacodynamic and kinetic parameters, and safety, and the contraindications, efficacy, and serious risk. Lack of granular data, they lack MIC. So it is like MIC near the breakpoint, but still it falls within the susceptible range or potentially affecting the treatment outcomes. Include all the culture sources like syndromic antibiogram aggregated from culture sources, infection with a multiple pathogen symptoms. So what is antimicrobial susceptibility testing? This evaluates the ability of antimicrobial agents to inhibit bacterial growth under standardized conditions. There are many like microdilution, diffusion techniques and gradient strip and many rapid diagnostic testings also. Results are reported as minimum inhibitory concentrations or growing inhibition zones categorized according to clinical breakpoints. Susceptibility testing guides both definitive and empirical antimicrobial therapy. What is the importance in the current context? It is increasing antibiotic resistance requires accurate susceptibility testing for effective stewardship. And stewardship aims to optimize use of antibiotics, improving clinical outcomes while reducing the resistant selection pressure. What are the methods of antimicrobial susceptibility testing? We have phenotypic, molecular based, and mass spectrometry. In phenotypic, we have the dilution, diffusion, gradient, chromogenic, and automated. And molecular based, we have PCR and cycle sequencing. And mass spectrometry, we have Maltov. what is the importance of moving beyond the traditional antibiogram? So moving beyond the traditional, we have molecular antibiograms in diagnostic clinical microbiology, which is helpful as a supplemental tool. Molecular antibiograms are also called as rapid diagnostic technologies, which is what is has improved the outcome by enabling targeted antibiotic therapy using clinical labs to detect antibiotic resistant genes for both diagnostic and surveillance purpose. It can directly be performed on the specimens like blood and respiratory samples. May not always Susceptibility testing may not always be conducted. Enhancing early empirical therapy by determining the resistant data, antibiogram can support early, more effective empirical therapy can be given. Predictive value, early identification of resistant markers, but missing data may limit stewardship interventions. Challenges with the GNB. Resistant prediction in gram-negative organisms is more complex due to varied mechanisms, leading to low accuracy in targeted antibiotic selection. According to a study of Origin BCGN platform, the analysis of 1,046 gram-negative bloodstream isolate showed that the absence of resistant determinants predict antibiotic susceptibility with high negative predictive value. Antibiotic de-escalation. In cases where resistant determinants are absent, clinician may safely de-escalate higher antibiotics to lower antibiotics, optimizing treatment strategies. Example of one gene detection is detection of MET-A in Staph aureus predicts methicillin resistance, allowing for precise antibiotic selection. Why we have to shift towards the faster detection? So molecular antibiogram detects resistant mechanisms at molecular level, offering very fast. It is like less than half an hour to 1 hour compared to the traditional methods, which take 16 to 24 hours. Originally developed for slow-growing pathogens like Mycobacterium and Helicobacter, now also available for common pathogens. Major advantages of molecular antibiogram is rapid detection, where time to response time is as fast as half an hour to 1 hour, reducing the wait time in the conventional methods, as I already told, 16 to 24 hours, works directly on clinical specimens, enhances sensitivity, capable of working on polymicrobial specimens, higher detection sensitivity, and reduced hospital stay and healthcare costs. What are the major limitations? Cost. It is very costly, limited detection scope, have a narrow resistant mechanism, meaning it provides less information compared to the conventional antibiograms. Detect resistant but not susceptibility. The absence of resistant mechanism does not guarantee susceptibility of an antibiotic. Unable to detect unknown resistant mechanisms which may emerge in future, limiting the ability. Qualitative results. It does not generate MIC values, which are crucial for stewardship, especially for specific drugs and pathogens. Risk of overcalling resistance. Due to detection of resistances that may be inactivated or not expressed, which could lead to inappropriate treatment choices. Inability to replace conventional methods. The technologies and systems of molecular antibiogram are, as we already told, gene amplification technologies, real-time PCR, PCR plus microarrays, PCR plus ESIMS, electronic spray ionization mass spectrometry. The resistance protein detection, fast immune chromatography, mass spectrometry, and the consideration in selecting commercial systems, coverage of resistant mechanisms. The system available vary in number and type resistance they detect. It's important to select a system that aligns with the local epidemiology. So first we have to see what are more common, then we can send for this because it is very costly and we have to send it very precisely. So implementing. So in a diagnostic workflow, when we implement, we have to consider the cost consideration, diagnostic workflow integration, incorporated strategically when diagnostic workflow to maximize its advantages. It may not be suitable for all specimens and should be used in selected pathways, particularly for high-risk patients. For instance, used for positive blood cultures in high-risk hospital settings, prioritizing samples based on clinical scores and biomarkers. In lab, 24/7 laboratory should be operational. Reporting. Information provided should be reports that presence of absence of resistant mechanisms, likelihood of resistance should be elaborated to understand. It can also suggest potential susceptibility to antibiotics not affected by the detected resistant mechanisms. Challenges in clinical reporting. Clinicians may not be familiar with the qualitative nature of molecular antibiogram results. So traditional antibiogram results should be correlated. It is essential to provide clear interpretation with accompanying comments that inform clinicians about the likelihood of resistance and susceptibility based on detected resistant mechanisms and bacterial species involved. These are the few examples. Expert Carba R, where IMP1, VIM, NDM, OXA48 are seen. This is expert MTB complex is an example. And this is a MyRitov in one institute. So clinical decision support systems, what is the role? It enhances healthcare by integrating patient data, providing targeted clinical knowledge and supporting clinical management. Evidence using this increases guideline concordance by 30% and ineffective antibiotic therapy in critically ill patients is reduced by 40%. What are the limitations of traditional antibiograms? They include outdated data due to infrequent updates, and data may reflect current susceptibility patterns for a specific syndrome or hospital location. Advancements with e-antibiogram. So electronic antibiograms along with the patient-specific data can use these antibiograms, and resistant can be with integration into the clinical decision support system has feasibility, user-friendly, but requires further validation. Weight incidence syndromic, this thing for personalized antibiotic selection, the weight syndromic combination antibiogram integrates real-time patient data to recommend empirical therapy tailored to specific infections. This is all about antibiogram. So we have to handle antibiotics with care. So I end this topic. Thank you so much, sir, for giving me this opportunity.
Thank you. Thank you, Likita. I think whatever had to be captured, you have captured in the very crisp but comprehensive manner. It is very important for us to understand an antibiogram. It is important for us to interpret an antibiogram. Sometimes what happens is the resistance pattern, you may not have the access to all the genetic analysis in all the centers or all facilities. So you look at the resistance patterns or the susceptibility pattern, you can actually guess what kind of genetic milieu your bacteria has, and that will help you to tailor your therapy. And what fact we need to remember is that whatever antibiogram shows is only in vitro susceptibility. It may not actually translate into clinical response in certain situations. The important other aspect about antibiogram is that you will know the quality of the lab. If a lab tests antibiotics which are intrinsically ineffective or resistant to a particular bug, or they choose antibiotics which are not known to be effective against that bug, then you don't need to go ahead and interpret the rest of the antibiogram. You know that the analysis is skewed. But every hospital, every ICU should have its own antibiogram, and it should be reviewed maybe every quarterly or at least every 6 months, so that what is the most susceptible antibiotic for which organism from which site of culture, if it is displayed or is known to all the end users, I think the use of antibiotics will be much more streamlined if we have to fight the menace of drug resistance. Johnson?
I think prescribing antibiotics is getting more and more complicated. So there was a time when a simple ceftriaxone and gentamicin would have covered everything. But today, getting your antibiotic prescription right, especially in nosocomial infection, is not that easy. And that is where having an idea about what is growing in your ICU, what is growing in your hospital, what is the resistance and sensitive patterns, and then choosing an empirical therapy in difficult situations is going to be of help. Once you are familiar as to what kind of organisms and what kind of resistance patterns are there in your ICU or hospital, in difficult situations, your empirical choice should or will help you cover those organisms, thereby increasing the probability that your first choice of antibiotics may be right. So please get familiar with what kind of resistance patterns are there by discussing the antibiogram with your respective microbiologists. Thank you.
Thank you, Nikita.
Thank you
Excellent
so
talk.
much.
Excellent talk. So, if there are any comments or questions regarding this topic, please do post them on the group from where you got the link from, and the speaker will answer them in the shortest possible time. Join us again next week for another interesting talk on the Higgs platform. Please subscribe to the channel and register for the 10th annual Higgs Symposium on June 19th to 22nd. Thank you very much. Have a good day. Bye bye.
Thank you, sir. Thank you so much, sir. Thank you, Ganashyam, sir. Thank you, Srinivas.